got this right, Andy, you said that if you have a partial knee replacement, you could stop the degeneration in its tracks. You know, you could stop the rest of the knee. That sounds to me then that if we've got pain in our knee, we should rush along and have a partial knee replacement so that we end up by not having any deterioration. On the other hand, of course, that if we start this process too early, then we could have problems later on, particularly if we live a long time.
Yeah.
So where is the happy balance?
So I think that's a really good point. And this is the issue about how early would you intervene to try and change the course of the disease, particularly if that patient hasn't got symptoms at the point at which you do your first operation. And that's a real struggle to know whether that would be the right thing to do. We don't know enough information. We're getting better, and we're starting to target groups. That's why our genetically loaded groups are very important for us to study, so we can see how they progress. Because part of the conundrum of osteoarthritis is there are patients who go through life and don't get any arthritis. And I think that's, again, another thing that probably amazes David and I, is that there are people who don't get any arthritis, whereas you think that they should, because they have the same mechanical environment as everybody else. The answer to your question is we don't know. I suspect that in 20 years' time there will be a way of identifying people at high risk. There will be early interventions that are hopefully at low risk to them, which will change the pattern of their disease. And that there will probably be a series of other things in terms of redesign of footwear, change the way that we understand about the way you walk, might be very important in initiation of arthritis in the knee particularly. And there will be a sort of a multi-level set of increments, perhaps not at many of them huge, but there will be ways of changing things at the next stage. I suspect you will still end up having a joint replacement at 70, perhaps, or 80, but you will be a lesser joint replacement, partial replacement, or something that at that point allows the progression of the disease to really stop.
Okay, thank you very much. Can I just carry on from there? Because patients often feel cheated, in inverted commas, if they come along and they've got pain in their knee, and someone tells them that, you know, it's not the time for an operation. Can you both say something about things like physiotherapy, drugs, or anything, so that the patient will feel happier that when they come to a hospital, they're not immediately admitted for a knee replacement that they think is going to take their total pain away.
So this is another very clear, but just I'll come back to you. This is a really important point. So the vast majority of people in the country with osteoarthritis of the hip and knee are not treated with joint replacement, are at a much earlier stage of the problem and are being successfully treated with interventions such as advice about lifestyle, weight loss, exercise, physiotherapy, tablets, so simple tablets such as paracetamol and anti-inflammatory medications in some instances can help the early stages of the disease. There are more speculative treatments, and I'm sure many of you have heard of glucosamine. It's called glucosamine. It's a tablet which is widely available and people think affects the biology of cartilage. And we don't have the evidence for that. But all of those things, if you look at the guidance from National Health Service, from NICE, from all bodies, anybody involved in treatment, and David and I, I'm sure would both agree, they're absolutely fundamentally important. At the early stages of the disease, to stop your symptoms or to control them, and even the later stages of the disease, to modify your symptoms so they are at least causing you the least disability.
I mean, from my point of view, the most extraordinary thing about arthritis is that we have really nothing, neither medical nor, for the majority of patients, surgical, that can really in any way interfere with the disease progress. No I mean, it's extraordinary. Rheumatoid arthritis, you can give them wonderfully expensive magic tablets that slows down the disease process. Osteoarthritis, we really have nothing that slows it down. So it is going to inevitably progress at the rate it was going to progress. All we can do is help the symptoms, and that's what all of those things Andrew was talking about. But what's interesting is that actually there are a few little subgroups of arthritis that we can slow down. Particularly there's this early type with the hips now, where there's an obvious mechanical problem causing early hip arthritis, and we're beginning to be able to prevent that. And I think the key message is once we can understand these mechanical problems, we may be able to address it, but fundamentally there's nothing we can do to slow it down. But it is really important. The vast majority of patients with arthritis are treated medically with all those things that Andrew talks about.
For the reason that if they have an intervention too early, and if they live a long time, they're looking at that huge long thing that you've just shown.
Well, the other thing that we sort of fundamentally believe is that there are no real nerves in cartilage, and you get symptoms, you get trouble, but not until you've worn down to bone. And then once you're down to bone, you get in trouble. And we go to great lengths to try to encourage people not to have a joint replacement until they're down to bone. Once they're down on bone, then actually you might as well have it.
And perhaps just to finish that point is that all of the patients who come and have a joint replacement, in actual fact, virtually everybody has tried hard to modify their symptoms because they've lived with the disease, as I'm sure you're all aware, for many years. And it's only when it's really severe and debilitating that a joint replacement is really indicated, because that's when you get the most benefit from it.
We could go on forever, but we're sort of getting on to what really interests us, and that's the indications for joint replacement. Who should you do? And it's interesting, of course, to observe that the numbers done in the Oxford region is actually less than other parts of the country, certainly less than many other parts of the world. But we actually looked at 5,000 patients that had hip replacements, and we sent them scores so we knew just how bad their symptoms were before they had the operation. And we subdivided them up into 10 groups, so those with terrible symptoms and those with mild symptoms. And however good or bad they were, they all got hugely better. And it's interesting, everybody but the top group, out of everybody but the top group, 97% were satisfied. And in the top group, they didn't do so well, 95% were satisfied. And it makes you realise that perhaps, actually, particularly for the hip replacement, maybe we're being too concerned. I just put that out.
Yeah.
But it is, the hip replacement is a really good operation. I think for knees, certainly total knees, we're not. We need to be cautious because, particularly in the young, they're not always